Yes, ma'am. Kasi sir, you're joined, sir?
Yeah, I think so. He's there.
Is there?
Yeah, no, I just think we might have to hang on for a few more minutes.
Yeah, he's joined.
Yeah,
He's back, like.
Yeah,
Start.
I'm getting his host disabled. Can I just check once more?
Yes, sir.
Thiru,
Please
Thiru,
go
I
ahead,
think,
sir.
Yes, sir.
yeah,
Go
I
ahead.
think he's made you as co-host.
Anybody on the attendees who need to be promoted as panelists, can you just have a look and then let
Oh,
me
one minute,
know?
1 minute.
Sumita Naik, madam, can be promoted. She's an ID person. Thiru, can you promote Sumita Naik?
Yes, ma'am. I've just done that. Yeah.
Lalita Janakiraman ma'am has also joined.
Yeah, they can be the list.
Okay, fine.
Fine, sir? Okay, sir.
Got it.
Thank you. So I'm sharing my screen, sir. Tirumurugan sir, I'm sharing my screen.
Hi, Sumita.
Good evening. Thank you, Dr. Janni.
Yeah, thank you.
Can you see my slides, sir?
Oh, yeah.
Start, Narmada.
Okay, shall we start, ma'am? I think
Yes,
we
yes. Yes, start.
Okay.
Very
Good evening, everyone. It's always a great pleasure to be part of the webinars of along with IAP TNSC and IAP TNSC Infectious Disease chapter webinars. The last one was a real big hit, and I'm very sure this chapter also will be this webinar also will be equally a great one. So let me start the day with proceedings with pediatrician prayer by our Dr. Narmada, Secretary for IAP Tamil Nadu State Chapter. Tamil Nadu Infectious Disease Chapter.
Thank you, sir. Pediatrician's prayer. எங்களுக்கு முழுமையான குணமளிக்கும் திறனை தாரும் நோயரின் துன்பம் தீர்க்கும் திறன் நமக்கு வழங்கப்பட்டது எப்படிப்பட்ட சிறப்புரிமை என்பதை பணிவுடன் நாம் உணர்வோமாக. எல்லா குழந்தைகளுக்கும் அவர் தம் குடும்பத்தினருக்கும் அவர்களின் சமுதாய நிலை மற்றும் சாதி மத பிரிவுகளை பாராமல் நலம், கற்றல், ஈகை, அன்பு, அமைதி ஆகியவற்றின் தூதுவர்களாக என்றும் இருப்போமாக. நம்மால் முடிந்தவற்றை மாற்றவும் நல்லவற்றை உள்வாங்கவும் மாற்ற முடியாதவற்றை காரணத்துடன் ஏற்றுக்கொள்ளவும் போதுமான மெய்யறிவும் புரிதலும் எங்களுக்கு வழங்குக. உங்களது வாழ்த்துக்களையும் அருளையும் கருணையும் எல்லா சூழல்களிலும் நேரங்களிலும் அனைத்து மக்களிடையே கொடுத்து அருளுங்கள்.
Thank you, Dr. Narmada. Without wasting much time, let us move on to the welcome address by Dr. Janani ma'am, chairperson for IAP TNSC ID chapter.
Yeah. Good evening, everyone. Thank you, Tirumurugan and Narmada. I think we decided to get back to the proper virtual meetings every month. Last month, we had the viral respiratory infections, and this time followed by that was again a very big hit. And again, we thought Narmada and me were discussing that we'll do something on vaccines, and we wanted none other than Dr. Kasi to be the moderator. Thank you, sir, for accepting readily, and thanks the panelists, Dr. Chandramohan, Dr. Ashwath, Dr. Suresh Balan, and Dr. Vasanthi for readily accepting to be the panelists. And I think this is again going to be a big hit because it's the need of the hour. We are still seeing respiratory infections in children, though the numbers have come down. But we should educate ourselves about the vaccines that are used for respiratory infections. And I think this panel is going to clarify all our queries. Over to I think Suresh Balan or Tirumurugan.
Yeah, it's over to Dr. Suresh Balan, ma'am.
President IAP TNSC.
Yes. Yeah. Suresh Balan, you can take
Very good evening, madam. So my welcome to all of you. Once again, I think I should appreciate the infectious disease chapter of our Tamil Nadu state for doing a phenomenal job, especially after the national program at Vellore. And now on the Zoom platform, they are conducting many programs. And I want to appreciate all their efforts, especially the chairman, Dr. Janani Shankar madam, as well as the secretary, Dr. Narmada Ashok, for taking all efforts. And today also, it has been a wonderful program on vaccines, the present and the future. So we have got an excellent moderator, Dr. Kasi sir, who is the advisor for the advisory committee on vaccine in India. So, and along with this, we have all our esteemed panelists here, Dr. Chandra Mohan, Dr. Ashwath, and Dr. Vasanthi. And
And yourself.
myself,
And
madam.
yourself.
Thank you. Thank you. I wanted to thank Dr. Janani madam for giving me this opportunity also. And thank you once again. I wish you all the best. Thank you.
Dr. Thirumurugan sir, do you want
I mean, I have nothing much to say except that you are the most vibrant subchapter of Tamil Nadu, and so it's great to be involved with your team, and so we are very happy to be part of it. And so, without wasting much time, let us move on.
I think we have some special guests, two of our Central EP members, Dr. Sumita Nayak and Dr. MS Vishwanathan sir. I just would like to just get a word of felicitations from them. MS Lee sir, please.
Thank you very much, and it's a very nice program. Looking forward, and I think we'll have a great attendance. Thank you very much for them. Thank you.
Thank you so much for joining with us, Dr. Sumita Nayak, ma'am.
Good evening, and thank you so much for welcoming me into this session today. It's always a pleasure and an extremely great learning experience whenever we have Dr. Kasi sir with us. So I'm sure this evening's program, which you all have so well curated, keeping in mind the current respiratory infections, I'm sure it's going to be a great learning experience. Good luck and thank you so much.
Thank you,
Sumita.
We also welcome Dr. Gopal sir, our treasurer of past treasurer IAP TNSC for the program. So without much delay, I'm just going to introduce our panelists. We have a moderator, Srinivasan Kasi sir. We are very honored by he readily accepted. Once we thought of vaccines in respiratory pathology, because Janani madam and we wanted to maintain the series, we discussed about recurrent viral infection. Then we wanted to go for the vaccines here. So thank you so much, sir, for accepting and for all the efforts you had put in for this program. He is a past president of IAP Bengaluru, past vice president IAP National Respiratory Chapter. He has been a member of ACVIP from 2011 to 13 and convener for 2021 to 21, and now he is in the advisory board of the same. I know ACVIP determines our vaccination for the entire nation, and he has also contributed chapters on vaccinology in various IAP textbooks. We are very honored to have you, sir. So joining with them are our esteemed panelists, Dr. Chandra Mohan sir, who has come all the way from AIIMS, Patna. He has 42 papers to his credit, and he's associate editor of Postgraduate Journal of Pediatric and Adolescent Medicine. He is also the member of ACVIP of IAP 2022-23, and he's a member Independent Ethics Committee of IAP. He's also been in the Pharmacovigilance program. Not to say he's most sought after speaker in many national conferences, and he has been awarded various scholarships to attend the Advanced Vaccinology course at Johannesburg, and he has also served in the executive board of Central IAP. We welcome you, sir, and we are very honored to have your presence here. And then none other than our most sought after speaker of Tamil Nadu, Dr. Ashwath, has done as a consultant pediatrician and neonatologist KMC. He was the first person who gave a note to this program as soon as we contacted him. And he wants to introduce himself as a perennial student and avid teacher for 2 decades. But we know that he's the most sought after faculty in the conferences, and we are very honored by your presence today. Thank you so much for joining with us, Dr. Ashwath.
Thank you.
And we are having a new speaker for IAP TNSC, Dr. Vasanthi Trivengam madam. She's a consultant at KKCTHS, and she's in charge of Department of Vaccinology. She's very exuberant, and every time I interacted with her during the program, she was so enthusiastic for the program. Thank you so much, ma'am, for spending your time with us. Dr. Suresh Balan sir, president of IAP TNSC and speaker in many conferences. I think Janani madam wanted the panel of IAP TNSC to be more involved in the subspecialty chapter. First time we had Thirumurugan sir, and we had an exciting session with him. And Suresh Balan sir definitely is going to add on. And he, though he's a professor in Kanyakumari Medical College, he has sat to study for this program. We're really very honored by your presence, sir. Thank you so much. So such an elite panel we have, and we are really looking forward to a great session today. Over to you, Kasi, sir.
Okay. Okay, at the outset, my sincere thanks to Dr. Janani Shankar, Dr. Narmada, and other members of the team IAP Tamil Nadu ID chapter for giving me this honor of moderating this particular panel discussion. Well, first it was COVID, And then came the adenovirus and H1N1, and we are literally drowning in an epidemic of respiratory infections. Apart from this present scenario, we must remember that respiratory infections are the major cause of mortality and morbidity in the under 5 population. In fact, India contributes to almost 50% of the pneumonia load in our own country, in the world. We have some excellent vaccines, probably underutilized to some extent. We have some vaccines which are almost on the table now, completing phase 3 studies. So I thought today it would be appropriate to look at vaccines against respiratory pathogens, what we have at present and what we are going to have in the very immediate future. I'm not going to talk about discuss vaccines which are going to come, which are still in the preclinical phases. So basically vaccines which we may see in the next maybe year, 2 years or 3 years at the most. So today we are going to discuss pneumococcal conjugate vaccines. There are a lot of new things emerged in this particular vaccines. We are going to discuss something about the inactivated influenza vaccines, BCG. Let's not forget that's also a vaccine against a respiratory illness, Pertussis, Measles, and of course, RSV vaccines, which are probably going to enter our clinical usage in a very, very short time. I am really very fortunate to have a very, very esteemed panel, and I'm very happy to note Dr. Ashwath is from GS Medical College. Incidentally, I'm also an alumni of the same college, probably 2 decades earlier than when he was over there. Okay, so now let's talk about pneumococcal vaccines. Okay, now, 1 second. Dr. Vasanti, can you give us a brief update and a recent update on the seroepidemiology of pneumococcal infections in India? Please remember, there's always a change in the seroepidemiology. What was true 20 years back need not hold true today. So are there any recent data about the seroepidemiology? Dr. Vasanti, please.
Yes, sir. Thank you so much for the opportunity, and thank you, sir, for doing everything for us. And it's going to be a really learning experience. And as you all know, globally, pneumococcal disease is a public health concern and a major challenge for developing countries like India, more so under 5 years and older adults. India ranks among the almost top 10 countries with the biggest mortality below 5 years. Going on to the several studies which have been done so far. There are several multi-centric studies and single-center data which document a substantial burden of pneumococcal infection in Indian children. Let's discuss a few studies. A systematic literature study from which was done by Jyotsna et al. In 2017. This is mainly an observational study. Documents the prevalence of serotype distribution of Streptococcus pneumoniae. The final analysis included about 7 studies. The most frequent pneumococcal serotypes, as depicted in the picture, were 14, 1, 19F, 6B, and 5, 6A, 9B, and 23F. Serotypes 4 and 19A were the predominant serotypes. The present review demonstrates that up to 78.4% of the reported invasive pneumococcal disease in children less than 5 years are currently the serotypes which are found in the vaccines. That is the vaccine the serotypes were included in the vaccines actually. Then secondly, the report from Dr. Reba Kunungo in 2015. This is a single center study by Dr. Balaji et al. From CMC Vellore, which included 114 isolates of Streptococcus pneumonia from invasive pneumococcal disease over a period of 6 years. That is from 2007 to 2016. This study and the IBS study showed that 24.5% of the isolates were of the non-vaccine type. The potential sources of these non-vaccine serotypes could be because of the colonization of the nasopharynx, which are also thought to be drug resistant. Then the third study from Chandigarh by Swati Sharma. She identified 6 different serotypes predominantly in our study, of which the most predominant one was 19F, followed by 6A, 6B, 61, which are the vaccine serotype, and 1 serotypes. The conclusions drawn were that the polysaccharide vaccine covered almost 96%, followed by PCV13. A case series from Bangalore, this is the fourth one, a case series from Bangalore by Dr. Rajagopal et al. From Bangalore showed evidence that all the 9 invasive pneumococcal cases have been caused by vaccine-preventable serotypes. So in conclusion, there are variable data from different centers and different geographical areas. A few of the centers have reported predominantly vaccine serotypes causing the pneumococcal disease versus a few others reporting non-vaccine serotypes. So we know that the genomic plasticity of pneumococcus is an essential factor in antibiotic resistance, serotype switching, and the emergence of non-invasive serotypes. Hence, it calls for a vaccine which has expanded serotype coverage and a higher valency for the vaccine serotypes. And moreover, a serotype-independent vaccine will be the need of the hour.
Okay, thank you, Dr. Vasin. That was really a very good review of the seroepidemiology. If you look at this Chandigarh study, it included, subjects of all ages. That is why there's a skewing for 19F. If you look at the previous studies were all in children below 5 years, and that's where type 1, type 5, 14 and all came into prominence, whereas the Chandigarh study involves all age groups. So the important thing to remember is that there are probably about 7 serotypes which are responsible for almost 90% of all IPDs. I want you to remember this data is about IPD and not respiratory infections. So if you have any vaccine having these 7 or 8 serotypes, you're assured of almost 70 to 80% protection. You gain something by adding more serotypes, which we are going to discuss a little later on. Okay. Now, if you look at the evolution of PCVs, we began with PCV7 in the year 2000, the beginning of this millennium. Then we had the PCV10 and PCV13 coming almost simultaneously, sometime around 2006-7. Then we had the PCV10, our own local brand of the Serum Institute. Now we have the PCV14 of biological Evans. Merck's MSD has now come out with the PCV15. Pfizer has come out with the PCV20. And who knows, we may having PCV20 plus 1, 2, 3, 4, 5, which we are going to discuss very soon. Now, whenever this talk of Serum Institute versus any other vaccine or one PCV versus another, there's a lot of talk about opsonophagocytic antibodies in protection against pneumococcal disease versus serum IgG antibodies against a specific serotype. So, Dr. Chandramohan, can you give us some idea what is this opsonophagocytic activity? How is it compared to the serum IgG antibodies? Can you just throw some light on this issue?
Actually, whenever there is a response post-vaccination, the serum IgG antibodies are formed against the capsular polysaccharide vaccines. And these has been traditionally measured by ELISA or immunoassays, and they were considered like they kill the bacteria, and that's why they are effective. But they do not give a perfect correlate of how does the vaccines work. Actually, for that, we need opsonophagocytic activities, OPA titers, because the IgG levels, that doesn't mean anything. They will be that is specific for a specific serotype. The SS antibodies, or their measures may be different levels for the different types of bacteria, but that will not give us any hint or any sense what is happening with the opsonophagocytic activities and how much the bacteria is being killed and neutralized by the antibody titers. For that, the OPA antibody titers are used. So those are the perfect correlates of protections. The normally 1:8 titers is considered as the opsonophagocytic. So if we get those titers, then we can have a good idea sense of if these titers are protective. So not the absolute titers in terms of ELISA of the IgG.
Right. So what Dr. Chandramohan has conveyed is that serum IgG antibodies includes both neutralizing and non-neutralizing. So it's a sum total of everything. The second thing is we must remember when you say 0.35 microgram per ml is the correlate of protection, what does it mean? It does not mean that for every organism it is 0.35. So what they have done PCV13, they have taken the protective titers against all divided by 13 and got the value of 0.35. For some, the levels may be lower, for some, the levels may be higher. And that's the reason why PCV13 hasn't worked too well against serotype 3. Okay. Whereas opsonophagocytic antibodies actually are involved in phagocytosis, which is the first step in the host defense against capsulated microorganisms. Of course, opsonophagocytic activity is a little more technically difficult test to do. It is done by flow cytometry, and it involves a lot of other techniques, technical issues also. So not very popular, but I think in the future, whenever one compares two bacterial vaccines, it would be more appropriate to consider opsonophagocytic antibodies rather than the total serum IgG antibodies. I hope this is very clear in the minds of the audience. Now, we all know that efficacy against invasive pneumococcal disease is 85–90% with the presently available pneumococcal vaccines, conjugate vaccines. But when it comes to pneumonia or otitis media, the efficacy is much less. Now, for example, pneumonia, the best figures given is 35%, nothing more than that, vaccine efficacy. Why is there this disparity? Dr. Chandramohan, you can take this again.
Actually, this is a very interesting phenomenon. The efficacy of the vaccine-induced immunity against the mucosal disease or non-invasive disease is much less compared to the invasive disease. The causes are that Streptococcus pneumonia itself, it is an exciting bacteria where this during the they undergo phase variations, and whenever they attack to the mucosal surface, the phase variation makes it like the capsular polysaccharides, they shift to a lower expression on the surface. Similarly, they also act on the IgA at the local site, and they do it. The IgA local site is not able to prevent it. Another factor is the shedding of the capsular polysaccharides to avoid destruction by the naturally present antimicrobial agents, peptides at the local site. So when they see this shedding of the CPS, that results they are not being destroyed at the local surface, and they can easily penetrate the mucosal surface of the respiratory tract as well as the lungs, upper respiratory tract as well as the lungs also. Another phenomenon is shedding of the CPS and the exposure of adhesins. That adhesins are the chemicals which facilitate the adhesion of the mucosal surface and where the colonization becomes much easy. So the mucosal surfaces are much easy targets by this streptococcal pneumonia due to their capability of shedding the CPS as well as their downplaying the expression of the capsular polysaccharide.
So basically, the first step in pneumococcal disease is colonization, right? Now, for the pneumococcus to stick to the mucosa, the adhesins, which are antibodies, which are antigens on the surface, have to be exposed. So that is why the capsular polysaccharides gets downregulated. There is shedding so that it can stick to the mucosa. So once the polysaccharide is shed, what is your pneumococcal vaccine PCV is going to work against? That's why the efficacy against nasopharyngeal colonization is very less. And for mucosal disease, which are basically the nasopharyngeal colonies, which are just moving along contiguous mucosal surfaces. So that is why against mucosal diseases like say pneumonia or otitis media, the efficacy is much, much less compared to its efficacy against invasive pneumococcal disease. This is something we got to remember, that this is a drawback of all pneumococcal conjugate vaccine. And remember, in our country, as a public health issue, PCVs have been introduced for prevention of pneumonias and not IPD, because we don't know what is the IPD load, and maybe it is very, very less compared to the load of pneumonia, the healthcare burden of pneumonia, the mortality and morbidity that pneumonia carries in our own country, especially many developing countries. Okay. Now, I've just made a short list of all the vaccines available in our country. The last two, PCV 15 and 20, is not available, so you can just keep it aside. Now, GSK has certain serotypes. PCV10 has of Serum Institute has certain serotypes. PCV13 is taken as a standard. PCV14 has one additional. It has dropped two and included one. So my question again goes to Chandramohan. Does increasing the serotypes in a vaccine equate with better efficacy, effectiveness, and impact? And lot of vaccines are dependent upon cross protection. 19F against 19A, 6B against 6A. Is cross protection as good as direct protection? Dr. Chandramohan, can you take this question?
So I'll take the first part. That is, it looks very simple. Increasing the serotype should increase the efficacy, efficiency, effectiveness, and impact. But no, it's not the case. Actually, this is a very intriguing situation. Increasing the number of serotypes in a vaccine, it does not necessarily equate to better efficacy, efficiency, and impact. While including more and more serotypes, it increases that coverage against the pneumococcal serotypes, but the net effectiveness will not be improved. It will only improve when there is an added serotype has a higher case to carrier ratio than the average case to carrier ratio in the current non-vaccine types. So there are for every non-vaccine types, there is a case to carrier ratio is there. If the ratio is higher, then only it will be useful. And another thing is adding a new serotype may decrease the overall potency of the vaccine against individual serotypes. So sometimes adding a new serotype decreases the antibody production as well as the opsonizing activity of the pre-existing another serotypes. So adding new serotypes is also a complex and costly things. So the effectiveness of vaccine also depends on the vaccine's total uptake and total penetration. So if a vaccine becomes so costly that its uptake is lessened, the finally vaccine effectiveness falls down. So these factors determine that more the merrier is not true for the serotypes.
Right. So,
and going for the cross protection, sir.
So Dr. Chandramohan, so what do you mean now? Suppose you take PCV10, I'm not mentioning any brands, versus PCV13 versus the PCV14 which is there. Yes, does increasing the number of serotypes not confer any advantage? What are the main issues when you choose a pneumococcal vaccine? There are two issues. One is that serotype present in the community? Is it a public health issue? See, if that is not there in the community, there is no idea in increasing the valencies. And secondly, you pointed out very well that as you go on increasing the number of antigens, there is interference between the different antigens. Remember, PCV13, if you compare the antibody titers of PCV7 versus PCV13 for the common serotypes, PCV7 elicited much higher antibody titers compared to PCV13. So there is a limit to the number of antigens you can introduce, the number of serotypes. You just can't go on increasing it without any limit, because it is definitely going to impact the immunogenicity of that particular vaccine. Now, the second part is cross protection as good as direct protection?
No, sir. The cross protection is not as good as direct protection, and there is no extra need of this by seeing only 6 and 19. So 6A, 6B. Initially, 6A was missing. 6B was understood that this will provide the cross protection against 6A. And in fact, the antibody titers were also high, but the opsonizing activity was not there. That's why in the subsequent batches, 6A has been also added. Similarly, with the 19 also, our experience suggests that even though the IgG antibodies are formed in sufficient GMCs measures, yet the OPA functional protection is not adequate. So cross protection may give a false sense of security if we get only the IgG levels, but the functional protection may not be effective.
Okay, so basically, when you take cross-protective antibodies, it protects only the vaccinated individual. There is no herd effect. Second, the duration of protection with cross-reactive antibodies are much, much shorter than directly reactive antibodies. So whenever you take any serotype, it's always better to have direct protection versus cross protection. Okay. Just to explain this a little more, this is the same table chart which was shown earlier. Now, if you see, I will talk only about the serotypes which are important in deciding which vaccine to use. 6B is about 8.8%, 6A is about 5.3%, 23F, which is present in the newly introduced PCV14, is about 4.9%, 33F is about 0.6%, and 18C is about 2.5. So you can very well say that a vaccine which contains all these serotypes is definitely quite adequate for our country. But at the same time, you must remember that seroepidemiology is not constant. Many times outbreaks are caused by serotypes which are not common in the community during other times. So I think the balance is tilted towards having more serotypes rather than lesser serotypes. I'm not talking from the public health point of view, but at least from an individual child in front of you, probably a vaccine with higher potency would be better than choosing a vaccine with a lower potency. Okay, right. Now, so with this background, Dr. Ashwath, very briefly, it's not a war between vaccines. Can you compare PCV10 of Serum Institute and PCV13 and PCV13 and the new PCV14 which has been introduced? Briefly, just give us the salient features of these vaccines.
PCV10 of Serum Institute has taken away 3, 14, and 3, 4, and 18 as compared to the PCV13. So we can see that the 3, 4, and 18 are missing.
Yes.
So their contention is that there will be some degree of cross protection. So even though 3 and 4 are not present, it will not affect the community performance of the vaccine. That is the claim of the vaccine manufacturer. But the second point, which has been very pertinently pointed out and repeatedly stressed, is we don't have local regional data from multicentric trial as to what are the serotypes present in Coimbatore versus Pune versus Patna. So the best of the multicentric trial will only be a guesstimate as to what is the actual cause of community-acquired pneumonia caused by pneumococcal or otitis media or pneumonia. So we have reduced the number of vaccines and thereby reducing the cost of the vaccine. It is a claim of the manufacturer that it does not significantly impact the efficacy of the vaccine, but that is a claim which cannot be proven unless we do a head-to-head trial.
So we have this new PCV14 now, okay, where, as you can see, 6A has been dropped because they say 6B gives very good cross protection, but they have included 22F and 33F. Okay, how will you compare this to Prevenar, to PCV13? I mean, does this change impact PCV14? Do you feel it confers any advantage, disadvantage? Of course, we don't have any data regarding the actual efficacy or ground level, how well it works. But since this is a vaccine with a correlate of protection, you don't need the data. How much difference will it make? What is the importance of having 6A?
PCV14 is basically PCV13 minus 6A with the addition of 22F and 33F.
Yes.
The logic is that 22F and 33F are emerging as new players in the presence of invasive disease and more disturbingly, a higher instance of antibiotic resistance. So they believe that 22F and 33F are emerging pathogens, both in causing invasive pneumococcal disease, pneumonia, as well as in the older population, and higher prevalence of antibiotic resistance.
Right.
Whereas the role of 6A has probably been overplayed from the Indian data. So this is the rationale that the B would be putting forward in justifying the inclusion of 22F and 33F and in the axing of 6A.
Okay, so what is your take? Which do you feel does PCV14 has any definite advantage according to available data? Or you feel it's just a play of words, play of numbers?
No, I genuinely believe that PCV14 has some advantage or added advantage in the addition of 22F and 33F. Because of the emergence of these two players as not only pathogens in pediatrics, but also in adult medicine. So every time we have a PCV vaccine, we have to remember that we are vaccinating the indirectly the elderly people, the family, because the nasopharyngeal carriage in the youngsters is the biggest source of threat for the unvaccinated adult population. So in that sense, 20F and 33F would be a
Okay, so
definite
yes, Dr. Ashwath, I think you brought it up very well. I think as of now, it's very difficult to make a choice PCV 13 versus PCV 14. 6A is also important. 23F, 33F are also emerging serotypes. They're also important for some of the outbreaks. They're also important, highly antibiotic resistant strains. I think over a time after usage, one can have a more clear picture about it. So I don't think we can make any preferences regarding which is better or which is a little inferior when you compare these two particular vaccines. I think we can just leave it at that. Any more discussion will rather make it more confusing. So I think we'll just leave it at this stage on comparing 13 and 14. Okay. Now, we have PCV 13, 14, PCV 15. For your information, there's a PCV 15 by Turgene Biotech, which has been granted market authorization, which will be entering clinical usage soon. Then PCV 20 of Pfizer. Are we going to have 25, 30, 35, 40? And second question is, are there any new vaccines in development whereby you can avoid this adding more and more and more serotypes? Yes. Who will take this question?
Myself, sir.
Yes, please. Yes, Dr. Sarath.
Okay. Thank you, sir. So already most of us has discussed, Streptococcus pneumonia is one of the bacteria which has got more than 90 serotypes. And most of the infections or the invasive disease are because of the 7 to 10 serotypes. And even though we have about many vaccines with 7 serotype, 10 and 13, already we have the 23 valent pneumococcal polysaccharide vaccine, but there is always a need for a new, effective and affordable vaccine, because already highlighted by Dr. Kazi sir, there is a serotype replacement phenomenon is there, where many of the non-vaccine serotypes always come into the picture because of their increasing invasiveness as well as the antibiotic resistance. So we have new candidate vaccines are there. One is the inactivated whole cell gamma irradiated vaccine strain is there, and other ones are the protein-based vaccines. And recently we have the so the previous one, sir, previous one. So we have one of the vaccines, which is a 24 valent PCV, the ASP 3772 serotypes, which include many of the serotypes in PCV 13 and 23, with the addition of 20B, which is complex in a unique fusion protein. And they are undergoing the phase 1 and phase 2 studies have demonstrated they are highly immunogenic, and in adults may offer a significant broader protection. And the other ones are with the pneumococcal virulent proteins, which have the virulence potentials, especially the pneumococcal surface protein A, and then the surface adenosine, the pneumolysine, and the choline binding protein. They are either recombinant proteins per se, which act either individually or in combination, and the pneumococcal fusion or the hybrid proteins, and the nanoparticle package fusion and hybrid proteins, recombinant protein boosted pneumococcal conjugate vaccines, and experimental PCVs in which capsular polysaccharides are linked to pneumococcal carrier proteins as opposed to either conjugated with DT or TT.
Yeah. So I think the field of research for better and better pneumococcal vaccines is moving at a very, very fast pace, because a PCV with a certain number of serotypes is always at a disadvantage because of serotype replacement. That is why PCV 7 went away, PCV 13 gave. PCV 13 is now going, and we are going to get PCV 15 and 20. In fact, 15 and 20 have already entered clinical usage in USA. The only way you can circumvent this is using some antigen which is common to all the serotypes. And these are mainly the conserved proteins. But none of these vaccines have even entered clinical trials. All of them are in the preclinical phase. So it's going to be maybe a decade before we can get them into clinical usage again. And incidentally, GSK, which are the makers of PCV10 Synflorix, they are now experimenting with the vaccine 10 valent, same 10 valent. To that vaccine, they are adding one pneumococcal protein to see whether it increases the breadth of response. Even that has finished preclinical studies and is going to enter phase 1 studies. So maybe for the youngsters over here in the audience and in the panel, they may see a lot more pneumococcal vaccines coming into clinical usage in the not too distant future. So there is still a lot of hope. Now, let's have some quick questions. Unvaccinated child, 2.5 years old. Does this child need PCV? If you say yes, which brand, number of doses? Dr. Vasanti.
If the child is healthy and 2.5-year-old child demand 1 dose PCV13 and 2 doses of PCV10, which is GSK, with the interval of dosing being 8 weeks.
Excellent.
If it's a PCV10 Serum Institute, it's not approved.
Exactly. Beyond 2 years, it's not approved for clinical usage.
And
unvaccinated child, 8.5 years. Does he need PCV?
Does not require PCV unless otherwise the child is immunocompromised or is at high risk.
Okay. Now, I think this is the answer to be given whenever this question is asked. But a lot of things are changing, especially in vaccination of immunocompetent children between 6 and 17 years. Some data is emerging. Maybe in the next webinar, when we discuss about this, we can talk it. But as of now, the message is beyond the age of 5 years, in an immunocompetent child, there is no need to give PCV. Okay, so I think this message should be very, very clear. Now, a 6-year boy recently diagnosed as homozygous sickle cell disease has received only the UIP vaccines. Obviously, has not received. This was at a time when PCV was not introduced in the UIP. What advice would you give to his parents regarding pneumococcal vaccination? Which brand? What is the schedule? Dr. Chandramohan, can you take this?
Yes, sir. So by the age is 6 years and the child has been newly diagnosed as sickle cell disease, we all know sickle cell disease makes the child vulnerable against the capsulated organisms. So the vaccine is needed, number one. Right. Child is more than 6 years, so that more than 2 years we cannot go with our Serum Institute, the brand. So the only vaccine which is available here for us is the PCV13. So one PCV13 and followed after 8 weeks by the Pneumo 23, we can go with that. And with the next 5 years, again, Pneumo 23 can be given. So the age at 6 years, this makes this option very simple. But if the child is below 2 years of age and the child has not been vaccinated, so we can go with the 4 dose of PCV13.
Right. So a child with sickle cell disease is very prone. One of the very, very high risk conditions for invasive pneumococcal disease and death due to pneumococcal disease. So definitely you have to give the vaccine. Obviously, we'll go for a conjugate vaccine. And for any individual above 6 years of age, they require only 1 dose of PCV13. PCV10 of GSK is licensed only till the age of 5 years. And as Dr. Chandramohan said, PCV10 of Serum Institute is licensed only till, I wouldn't say licensed, but recommended, licensed only till 1 year of age, but IAP has recommended it 2 years, WHO has recommended for 2 years, so IAP has also recommended the same. So the choice is left only to PCV13. So 1 dose of PCV13, 8 weeks later, you give a polysaccharide vaccine. And 5 years after that, you repeat a 2nd dose of polysaccharide vaccine, and you don't repeat any more doses because of the risk of hyporesponsiveness. Please remember, hyporesponsiveness does not mean only failure to respond to the next dose. It also interferes with pre-existing antibodies. So it's not a good thing to have. So you should not give additional doses of pneumococcal vaccines. The polysaccharide vaccine, only 2 doses. And remember, the 2nd dose of polysaccharide vaccine is required only for immunocompromised conditions. Cochlear implant, you will not give the 2nd dose. Asthma, diabetes, other metabolic conditions which are where there is no immunosuppression, you'll use only 1 dose and not 2 doses. I think this is just by the way. Okay. Now, we are finished with pneumonia. Now let's come to acute otitis media. What is the role of PCVs in the prevention of acute otitis media? Yes.
PCVs are useful, very useful in acute otitis media, and various studies have shown that it prevents it depends on the age group. Below 2 years, it's the most effective, and up to 5 years also, it's very useful. So below 2 years, it's between 8% to 68% chance of reduction, on average for around 40%, and below 5 years also 39-40% chance of reduction in AOM has been reported. So efficacy is low, 5 to 7%. It depends on the types, whether clinical or what is the condition. The efficacy is low, only 5 to 7% in the against clinical AOM, but it's very high against if the hospitalization, it's around 45%. Most important for below 2 years, it goes beyond 50%.
So basically, the efficacy against prevention of acute otitis media depends upon what is the stage of otitis media and what is the age of the child. PCVs work much better against the severer forms of otitis media or its complications, mastocytitis, etc. The efficacy against uncomplicated AOM or AOM with emergency department visits or clinic visits, the efficacy is much less. But even that is of a definite advantage if you look at the numbers. I mean, huge numbers of acute otitis media, and look at the amount of antibiotic prescription that occurs with every case of otitis media. Okay, so I think although the efficacy is less, 4%, 5%, 7%, the impact is going to be tremendous. So we have to remember in mind that PCVs, we are not giving it just for pneumonia or IPD, we are also giving it for acute otitis media. The other question comes is NTHI. I think we will just discuss it because that vaccine is no longer available in our country. But incidentally, NTHI, addition of NTHI has made a marginal difference. But there is also a lot of discrepancy in this data because NTHI may not be the primary pathogen. It piggybacks on the pneumococcus to exert its infective effect. So probably studies from Israel have clearly shown that even PCV13 has reduced the incidence of NTHI by almost 75 to 80%. So probably NTHI is not very important in the etiopathogenesis of pneumococcal AOM. But remember, prevention of AOM is also one of the major advantages of the use of pneumococcal polysaccharide vaccine. Now, we know pneumococcal vaccines protect against pneumococcal pneumonia. But is there any role in prevention of morbidity or mortality associated with other viral pneumonias?
Yes, sir, definitely. And more so in the COVID, we have seen this giving it a surrogate protection. So with the COVID, we had seen that around 64% protection vaccine efficacy was observed. They had a lower incidence of COVID-associated pneumonia hospitalizations among PCV recipients compared to placebo recipients. Similarly, for the other viruses, virus-associated lower respiratory infections, viral-associated pneumonia, as well as the episodes of where the patient does not need hospitalization, outpatient settings. In all three situations, around 24% reduction against the virus-associated pneumonia, 22% around the virus-associated LRTIs, and 27% where the LRTI episodes requiring hospitalization.
Inpatient.
So all these have statistically proven that whether influenza A, influenza B, coronavirus or parainfluenza or human metapneumoviruses, all these viruses, they may secondly complicate the bacterial pneumonia. So once the pneumococcal vaccine has been given, the incidence of the pneumonia due to the viral antigens are also reduced. So this is a much more effective against the overall protection against the lower respiratory infections, be it other viruses also.
So I think the message is When you have influenza outbreaks, when you have adenovirus outbreaks, please check on the PCV vaccination status of the child. There's a definite role of pneumococcal conjugate vaccine in reducing the morbidity and mortality associated with pneumonias caused by other viruses. Only thing, it hasn't been shown to work very well against RSV and the adenovirus, but against influenza, parainfluenza, and even COVID, pneumococcal conjugate vaccines reduces the incidence of that corresponding viral pneumonias. Okay, so as we have seen, PCVs protect against IPD, PCV protects against pneumonia, that is mucosal pneumonia. PCV protects against acute otitis media and its complication, and PCV also protects against pneumonia caused by other virus. A very, very versatile vaccine. And I think this vaccine is something that has to be there, given to every single child. We have now low-cost vaccines. The government is giving it. We should see that every child under our care receives a pneumococcal conjugate vaccine. Okay, now we come to the second vaccine, influenza vaccine. Recently, with the outbreak of H3N2 gaining so much of media coverage, I think clinics are crowded with patients demanding influenza vaccine. I mean, they have missed the vaccine for 2 years. They have missed so many other vaccines, but they say, give me the influenza vaccine today, I'll come for the other vaccines on some other day. That is amount of media hype associated with influenza, which has sort of spurred the need for influenza vaccine. I think we should look at this from a more realistic point of view, and that is what we are going to discuss in today's panel. Okay, Dr. Ashwath, we started with 0.25 ml for those less than 2 years of age or 3 years. And above that age, we were giving 0.5 ml. But today, now, 2020, the ACVIP recommended a common dose of 0.5 ml for all the children from 6 months onward. Why was this change done after so many years of usage of influenza vaccine?
It has to do with the way the influenza vaccines have evolved over time. So initially, what people were using was the viral inactivated whole virion vaccine, which was highly reactogenic. So the younger the age group, between the age of 6 months and 36 months, the higher doses elicited more side effects. Therefore, there was a resistance to using the higher doses in younger children. Therefore, there was a recommendation that between 6 months and 36 months, one would be giving 0.25 ml. Beyond the age of 36 months, we could use a 0.5. Now we moved away from those whole virion inactivated vaccines, phenol-filled ones, to subunit and split virion vaccines, which are far less reactogenic. And we also recognize that influenza's mortality is much more in children lesser of 5 years of age. So it is imperative that the best antibody titers are produced in the most vulnerable population, which is children less than 5 years of age.
Right.
So less reactogenicity and more need for higher hemagglutinin and neuraminidase titers prompted the need to switch to one vaccine for all the group.
So basically, if you compare 0.25 ml and 0.5 ml, reactogenicity does not increase in the population below 3 years of age or 2 years of age if you give 0.5 ml. On the other hand, definitely it induces a superior antibody response. And we know influenza vaccine, we have a correlate of protection. So in this case, especially for the youngest infants, between 6 months and 1.5 years, the increase in antibody titers, especially against the H1N1 strain, is statistically very significant. So definitely there is going to be similar reactogenicity and much superior efficacy. That is why the world and even India has changed out of a uniform dosing schedule for influenza vaccine for all children above the age of 6 months. Okay. Now we have some data about the burden of influenza in India. Yeah, right from many, many years we have data, and we have evolving data. Dr. Ashwath, is there any data about how well the vaccine works in our country?
Sadly,
Any study?
No, sir. No, sir.
Not a single study?
To my knowledge, none, sir.
Right. I think what you have said is partly true, except for one article by MS Chadda, which was published way back in 2012, where they looked at the influenza virus for about 4 years. They looked at the strains and they compared it to the vaccine strain, and they said there was a match, but there has been absolutely no efficacy data from our country. Something we need to keep in mind. Is there any strain mismatch, Dr. Ashwath, in our country?
So first we need to understand this word strain mismatch.
Yes,
so the
please.
WHO keeps recommending a northern hemisphere and a southern hemisphere vaccine basically for use against influenza when it comes to the inactivated influenza vaccine. Unfortunately, we know that the hemagglutinin neuraminidase continues to undergo constant juggling around producing antigenic drifts and shifts. So by the time your vaccine has elicited a significant hemagglutinin or neuraminidase antibody titer, it is possible that the virus is also undergoing some change and eluding the antibody response. So we are always going to be one step short of getting the perfect vaccine, and strain mismatch, even with the best of surveillance, is probably happening but unknown to us. There is a need for us to keep on vaccinating year after year and to follow the WHO's recommendation. It is definitely there, but we do not know from individual centers whether there is a strain mismatch.
Okay, so now we don't have any efficacy data. We do not know whether the vaccine strain and the community strain, circulating community strain, are really matching or there is a mismatch. We don't know anything. But we know that below the age of 5 years, influenza carries a very high, significantly more morbidity, mortality. So, well, up to 5 years, fine. Let's give everyone the influenza vaccine. But what are your thoughts regarding routine influenza vaccinations for otherwise healthy children more than 5 years of age? I'm sure in your clinics you have been giving influenza vaccine to all ages now because of the demand. What are your thoughts about this routine? Say, suppose COVID is gone, we don't have outbreaks, it's just part of the routine immunization. Will you offer it to children above 5 years also?
So this answer is very closely allied to the answer which we discussed for the pneumococcal vaccine for otherwise healthy immunocompetent children.
Right.
We have data to say that influenza as a disease either primarily or whether it induces a secondary bacterial superinfection. We understand that the morbidity and mortality is much more in the age less than 5 years. So my take is that if the child has got a comorbid condition like a rheumatic heart disease, or is an asthmatic, or is a child who's an nephrotic syndrome, steroid dependent or resistant, who's getting repeatedly exposed to steroids, or in some cases where I practice, there are lots of boarding schools which insist on the influenza vaccine be given for children regardless of their immune status as a precondition to taking them into the boarding school or hostel. So apart from these special situations, I don't think the burden of influenza in India warrants routine vaccination for all children beyond the age of 5 years.
I think I would rather modify that sentence and say at present we don't have sufficient data to recommend routine immunization with influenza vaccine beyond the age of 5 years, except those with special situations where the risk of influenza is much higher and mortality morbidity due to influenza is also much higher. Okay, now we know that southern hemisphere strain is the one which we use in our country. Then why are we using northern hemisphere at all? Why?
So India is basically not just a country, sir. I think it is more of a continent in the way it behaves. More so with respect to influenza epidemiology, we are geographically above the equator, so we fall in the northern hemisphere. But then the Tropic of Cancer cuts our country into two halves. And if we look at the seroprevalence and the behavior of the influenza virus and its epidemics and its seasonality, we see the north of the country behaving more like the northern hemisphere and the south of the country behaving more like the southern hemisphere with respect to the epidemiology of the influenza illness per se. So the WHO, even though India belongs to the northern hemisphere geographically, has placed India in the South Asian zone of influenza spread. Therefore, it is quite appropriate for us to follow, for the most of the population, the southern hemisphere strain, whereas the northern hemisphere strains would be more appropriate for the northern parts of the country where the epidemiology of the influenza illness is very different from that seen in South India. So both are appropriate. We need to choose what is the best current available, most recent strain of influenza. So I believe we have a need for both of them.
Okay, suppose it's the time of the year when only Northern Hemisphere strain is available. Will you offer the vaccine in Chennai or Coimbatore, or will you postpone it and say you come after some time when the Southern Hemisphere is available? Why do we?
No.
Yeah, you said no. Can you say why? Why no? Why don't you want to? Why do you not want to postpone the vaccination for a strain which we feel is more suited for our country?
Come again on the question, sir. I didn't get
The question is, you're in Chennai or Coimbatore. You have only the Northern Hemisphere strains. We know Chennai, Southern India follows more of the Southern Hemisphere strains. But in this situation, are you still going to give the Northern Hemisphere or postpone the vaccination till the Southern Hemisphere strains are available?
As I qualified that statement, if the child's health needs are persistent, pertinent, and the child needs protection against influenza virus, I'll go ahead with the most recent, best available vaccine at that point of time, rather than wait for the new vaccine to come. Because it's an annual vaccine, I can always catch up with this child on the Southern Hemisphere, which is probably more appropriate to the geography. But I will not delay this baby the vaccine.
Excellent. And the second thing is, influenza is not a seasonal disease in our country. It occurs year round. So even if a child is born in November or December, which is not the influenza season for the major part of the country, one should not postpone the vaccine, but give whichever strain is the most recent strain. Suppose you have both Southern Hemisphere and Northern Hemisphere available. And if the Northern Hemisphere is a newer strain, still you should prefer the Northern Hemisphere because it is a newer strain. Why I'm saying is, remember, for a Southern Hemisphere vaccine, which comes in March, the decision on the strains was taken in the previous year's September. And that decision was based on data of 1.5 years prior to that. So a lot of time has elapsed. The influenza virus has got a lot of time to do, a lot of antigen drifting. So I think it's always better to use the most recent strain, irrespective of which part of the country you're in, right? Okay. Now, Dr. Suresh, influenza carries the highest mortality and morbidity in infants less than 6 months, just like Pertussis. How will you protect these young infants? Dr. Suresh, please.
Yes, sir. Yes, sir. So, the statement goes, influenza as a virus has got a highest mortality in these younger age group infants, and naturally, when it like COVID only. So, when we are going to protect these infants, we have to take it into two areas. One is the maternal immunization, or the infants where they are in the household. So, for the caregivers and the household members, definitely they have to be given a shot of influenza vaccine when it is available.
Okay, now let's stick to maternal immunization only. So, yes. Maternal immunization, one of the key ways in which you can prevent influenza in the first few months after the baby is born. Yes. Which particular period of pregnancy will you give the influenza vaccine?
Yes, sir. Even though the influenza vaccine inactivated is not having a teratogenic effect or not having much of adverse events, but usually we recommend it after the second trimester or the third trimester. And there are some studies which also say that there's a meta-analysis of 16 studies which say compared to vaccination in earlier trimester with those of the later trimester, they say that there is a greater fold increase in the hemagglutinin inhibition titers when given at the later trimester when compared to the early trimester.
See, when you're giving maternal pertussis immunization, you're giving it essentially for protecting the baby and not the mother.
Yes.
Right? But here, when you're talking about maternal influenza, you're also talking about protecting the mother as well and the infant.
Yes, yes.
And remember, pregnancy is a very high-risk situation for influenza. The incidence of pneumonia and many other complications are much higher in pregnancy. So that is why the WHO has recommended that give it any time, the earlier the better. And I feel you should qualify your answer and state that if it is in a period of influenza outbreak, irrespective of which trimester the vaccine should be given. Even in the first trimester, it has been shown to be a safe vaccine.
Yes.
So
yes.
during outbreak situation, don't wait till the ladies in the third trimester, give it as and then, because it will protect the mother and some protection will be there for the infant. But of course, you can't give 2 doses, first one in the first trimester and another one in third. That has not, I mean, there is no study, no recommendation as far as that is concerned.
So if you give too early, what will be the antibody response?
Exactly. But as I said, it's a trade-off. You want to protect the mother as well. So in that case, you give it as early as possible whenever the outbreak is there. You don't postpone it, right?
Okay.
Now, how effective is this maternal immunization in preventing illness in the infants? Are there any studies, anything, Dr. Suresh?
Yes. So there's the mother's GIFT study or the GIFT study, which is RCT, which is conducted in Bangladesh, involving 340 moms, and they have compared the mother and infant pairs. And they have found that the vaccine efficacy against the lab-confirmed influenza was around 63%. And against the ILA in babies, it was 29%, and ILA in moms, it was around 36%. So the conclusion is the maternal vaccination benefits both the mothers and the babies less than 6 months of age. And so the take home is the influenza vaccination in pregnancy. So it prevents influenza illness in women until 6 months postpartum. It prevents influenza illness in infants until 6 months of age, and it prevents influenza-related hospitalization in the infants.
Yes, there is also other studies from South Africa.
With regard to vaccine efficacy with the RT-PCR confirmed influenza, again the same results at around 50%, both in mothers and infants. And another one is the odds of preterm births was lower among infants of vaccinated women than among those of non-vaccinated women. So the rate of low birth with infants was also lower among the vaccinated women.
So influenza vaccine, maternal immunization, take-home points is one, influenza vaccine has been proven to be safe in pregnancy. It can be administered anytime in pregnancy. And it is intended to protect both the mother and the unborn child till the baby is about 4 or 6 months of age. And apart from just preventing influenza, maternal immunization with influenza vaccine has been shown to reduce the incidence of preterm births and low birth weight infants. So a lot of benefit in maternal immunization, which I feel you should really convince your gynec colleagues, your OBG gynec colleagues to take it up on a much more larger scale. Now, what is the duration protection? Now, why I'm asking this question is 2009, you have a certain strain. 2010, it's the same strain. Do we still have to repeat the vaccine? What is the duration of protection? Dr. Suresh.
Okay, sir. So the anti-HA antibodies usually rise up within 2 to 4 weeks in a primed individual, and it is more than 4 weeks in an unprimed individual. In general, the antibody fall by 50% after 6 months. So it depends as well on the peak titer, which has been achieved initially. And the vaccine strain as well as the circulating vaccine strains, if they are similar, then there is a protection of up to 6 to 8 months of age. And overall, the vaccine efficacy is around 30 to 70%.
Yeah. So vaccine efficacy depends upon many factors. I mean, what is there a match, mismatch? What is the end point? Vaccine efficacy will be higher against lab confirmed influenza. It will be lower against ILI. So there are a lot of variations, variables when you're considering the efficacy. And you must remember, influenza vaccines are inactivated vaccines, but they're not adjuvanted. So obviously the antibody response is going to be suboptimal. Duration of protection is going to be very short. They have shown a fall in titers within 8 to 12 weeks of giving the vaccine. So the duration of protection is really 4 to 6 months maximum. And this is sufficient for countries which have only seasonal incidence of influenza, where it begins every year in October and goes on till February or March. But what happens in a country, tropical country, where we have year-round transmission? We don't know. There's no answer to this particular question. There are no alternatives. We still follow the yearly influenza vaccine only. Now, a very common thing is we are scared to give influenza vaccine to children with egg allergy. How will you manage the situation? Mother comes and says, you know, he had eaten some egg when he was about 10 months old, and he developed some rashes. We never gave egg after that, but he eats cakes which may contain eggs. You know, she gives this history. Once you say, is there any history of egg allergy? I'm sure all of you will ask for history of egg allergy before giving the influenza vaccine. How will you manage this child?
Most of the current vaccines are using only the vero cells for the vaccine. And so not much of concern with regard to egg allergy. But if there is a history of allergy and there is a history that one system alone is involved, like urticaria or the hives, so we can safely give the vaccine, observe the child for about 15 minutes in our OPD with all relevant precaution measures if needed. But if there is a history of severe anaphylaxis or more than one system involvement like the respiratory or the cardiovascular system, then we have to be more careful. We have to have all the necessary medicines, rescue medicines in place, as well as intensive care setup we have to give.
Yeah. So what you said is true. If it's a single system, only cutaneous involvement, safely give the vaccine in your clinic. Observe the child, have your adrenaline and an oxygen cylinder ready in your clinics. Okay, to handle in case there's any anaphylaxis. But if the child has had any multi-system involvement or cardiac, respiratory event following a consumption of egg, I think please don't give in your clinic. This can be given in a hospital setting where immediate resuscitation is possible. And incidentally, egg allergy is a precaution for influenza vaccine. It's not a contraindication. We should be very clear. The only vaccine which is contraindicated in egg allergic individuals is the yellow fever vaccine. That's the only vaccine. Otherwise, influenza vaccine is only a precaution and not a contraindication. Now let's come to some practice parameters. Quick answers. 4-year-old child received the first dose of inactivated influenza vaccine at 6 months of age and now comes at 4 years for vaccination again, because now there's outbreak. 1 dose or 2 doses? Dr. Suresh.
Sir, between 6 months and 8 years of age, 2 doses are recommended. So if the child has received only 1 dose, then we have to give the second dose, 2 doses.
So this child you will give 2 doses, right?
2 doses, sir.
Okay. Another 4-year child has received 1 dose at 6 months, second dose at 2 years, and now comes to you for vaccination at the age of 4 years, having taken 2 doses in the past.
Only 1 dose is enough, sir. 1 dose.
So the recommendation state that if anyone has received 2 or more doses of influenza vaccine in the past, these doses may not have been given in the same season or year. It is taken as a valid, completed primary schedule. You need to give only 1 dose. But if it is less than 2 doses obviously means 1. It cannot be 1.5. So it less than 2 doses, then you have to restart the schedule with 2 doses. I think this is an important practice parameter as far as influenza vaccine is concerned. Well, annual influenza vaccine, strain mismatch, it's a toss of a coin, when you're talking about influenza vaccine. So there is a search for a universal influenza vaccine. We have been hearing, I'm hearing about this at least for the past 20 years, ever since I became interested in vaccinology. Is it a pipe dream or is it going to be a reality?
So this universal influenza vaccine is a vaccine which is effective against all the influenza strains, regardless of virus subtypes or the antigenic shift or drift.
Right.
And it needs no modification every year, sir, the strains. But is it a reality? We have to see. The first trial of a nanoparticle influenza universal vaccine is on clinical trials, which is the Flumos V1, and which is expected to generate a long-lasting immunity and to protect against the existing as well as the emergent strains. So this is some of the list of the this universal immunization influenza vaccines, sir.
Yeah, the ferritin-based nanoparticle vaccine, which use the hemagglutinin stock as the antigen, is the one which has entered phase 1 trials now. It has completed preclinical studies. That's the only protein-based vaccine which has entered clinical trials. And what is more interesting is mRNA vaccine, where they have encoded the mRNA of 20 different strains into one plasmid. that vaccine has shown a good immunity against all the different strains. Okay, even dissimilar strains. So mRNA vaccines are probably going to be the vaccines of the future as far as infectious diseases or pandemic prone vaccines. mRNA vaccines are going to play a very important part. So I don't think it's a pipe dream. A lot of things are going on. Only one vaccine has entered phase 1 trials, clinical trials, 5 years, 10 years, but it will definitely come. And at that time, I think you may need to give the influenza vaccine just priming and boosters like we give with DPT or Hib or pneumococcal vaccines. Okay. Now we come to an age-old vaccine, BCG vaccine, which is almost about 120 years old vaccine and probably the vaccine most widely used vaccine. And they say almost about 1.9 billion doses are given every year. So what are the limitations of the present BCG? Why are we looking for better vaccines? Dr. Vasanthi, can you just briefly tell us what are the limitations?
BCG vaccine, the efficacy is variable, especially in endemic countries like India, as every susceptible person is already exposed and has natural immunity. So BCG can hardly protect these individuals. And exposure to environmental bacteria like atypical mycobacteria provokes a non-specific immune response against mycobacteria and does not augment the response to BCG.
Right.
And different genetic makeup of the different populations in turn can also cause difference in efficacy. Genetic variation in BCG strains themselves can also cause a variable efficacy, which is demonstrated in different trials. So these were the things I thought would limit the BCG administrations and BCG vaccine.
No, do you mean to tell that BCG has no role? It is not helping children in any way?
It does have a role, sir, but then these are the small minor problem like genetic makeup and variation BCG strains, which could again influence the uptake of BCG.
So basically, prevention of the primary complex, the protection is very, very variable and disappointing. Prevention of post-primary complications, efficacy is almost about 80%. BCG as a booster is of no benefit. Composition of BCG varies, efficacy varies, reactogenicity varies. And lastly, you cannot use BCG in an immunocompromised child. And especially with HIV, which is still there quite rampant in few continents, we need a vaccine which does not have these shortcomings. I think these are the main drawbacks of the BCG vaccine. What is our BCG and what is its development status?
So this is the new recombinant BCG vaccine which is being evolved. So it actually improves immunological memory and protection. It also enhances the immunomodulatory potential of the vaccine. It also provokes mammalian cytokine production. It augments the protective potency of BCG against tuberculosis also, and increases the potential as an anti-cancer agent. And this includes an overexpression of the immunodominant antigen, which is lost during the BCG attenuation, which provokes a better T immune and cytokine response.
Okay, so basically these are in general what you have mentioned about our BCG. And I think one recombinant BCG is now in phase 3 trial. Can you give us some idea about that vaccine, what it is?
Yes, this is the VPM 1002, which is a live recombinant vaccine from the Serum Institute, in which the urease C gene is replaced by the listeriolysin encoding gene. And this is being evaluated to assess the ability to reduce the infections and severe disease outcomes of COVID-19 among high-risk persons of advanced stage and those who have comorbidities, and also it may be useful in high-exposure healthcare workers. So the trials for VPM 2002 and the Immunovac being conducted in 18 sites in 6 Indian states, of which 2 sites are in Pune. And the other 60, there are almost 16 different vaccines and clinical trials, of which 8 vaccines on phase 2 and phase 3, and remaining 8 on the phase 3 trials.
Right. So when you talk about the newer BCG vaccines, they are classified as prevention of infection, where you give in the newborn period, prevention of disease, where you give it to adolescents and adults, prevention of recurrence, okay? these are the main, and of course, therapeutic vaccines. So there are 4 categories. And in fact, VPM 1002 is a very, very versatile vaccine. It's being investigated for all the 4 parameters. And a phase 3 study has started in babies in South Africa. In India, there are 3 phase 3 studies going on where it is being studied both for, one is prevention of reinfection in those who have already had the disease. It is also being studied in another phase 3 trial where it is being tested for efficacy of preventing tuberculosis infection in household contacts of open cases of tuberculosis. And I think this is a vaccine which, if proven successful, may replace BCG for the neonatal immunization program. Apart from that, the other one is the MTB vac, which is again a live attenuated vaccine with a lot of genetic mutations which have attenuated that particular vaccine. And MIP is a very interesting vaccine. MIP is again an Indian product, make in India. It's called Mycobacterium indicus prani. Now, this vaccine has been licensed for leprosy. But what they have found out is that it had some efficacy against tuberculosis. So now it is being investigated for prevention of tuberculosis, especially in those who have category 1 tuberculosis. And it is being compared with Immunovac, which is another vaccine which is being used. So basically, I think we have quite an exciting pipeline of vaccines for tuberculosis, and especially with VPM 1002. I think there's a lot of hope regarding that vaccine. So far, the vaccine has done exceedingly well in all the trials till stage 2B. Incidentally, the previous era's GSK vaccine failed to, satisfy the primary parameters in its phase 3 trials, and that development has been totally given up. So we're going to see a lot of new vaccines. BCG has its limitations, but it's the best we have. Until a newer vaccines comes, we have to continue with BCG. Okay, now we come to some comedy of errors, I call this. And I think this is something many people may encounter. Staff nurse erroneously administered 0.5 ml of BCG into the right thigh instead of 0.5 ml of hepatitis B vaccine in a newborn baby in the maternity home. How will you manage it? What do you expect? How will you manage this situation? Dr. Ashwath.
So this is a fairly common mistake we make. It should not be made, actually. So here what has happened is against the dose of 0.05 ml, which is what is recommended, that to intradermally, 10 times the dose has been given, and it's been given intramuscularly. So what we can first do is genuinely come clean and apologize to the parents for the mistake that has been happened on behalf of the nurse, and tell them that this child, because of the superior vaccine BCG load that has been delivered to the baby, we can expect a more robust local and loco-regional complication. This sense, the baby is likely to develop a bigger papule or nodule in the thigh region where the vaccine was given. I would also be warning them that there can be an inguinal lymph node which may enlarge in that site, and that there is a possibility that the swelling will persist for a while and may soften and may actually ulcerate and discharge through the skin. But with conservative management and patience, not too much of harm would come to the child. I am assuming for practical purposes that the child is immunocompetent. And last but not the least, the staff nurse will be getting only 0.5% of her salary.
Do you think this vaccine will work if you give it separately?
We do not recommend, or we don't have data to suggest that BCG given by any other route like subcutaneous or intravenous or intramuscular is work. The studies have always been looked at only the intradermal routes.
So basically a non-standard route here, it should be an invalid dose. Here what has happened is the vaccine has been given IM. So you're not going to have any skin lesions at all. You're only going to develop a reaction within the muscle tissue. And I think I have had at least 3 kids with this problem over the last 15-20 years of my practice, of my active vaccinology practice. And all of them developed an abscess, and all of them needed repeated aspiration, but one message to go very, very clearly and loudly is no antituberculous treatment. Okay, because in an immunocompetent child, there is absolutely no need for antituberculous treatment. That is one very important message that has to be conveyed as far as a similar error has occurred. Now, how many of you all know about Onco-BCG? You see, Onco-BCG is something that is used for bladder cancers, and it has 100 times the content of the conventional BCG, the antigen content. And I have had 2 children who were administered Onco-BCG 0.05 ml instead of the regular BCG. What is to be expected?
Again, because this is very similar to the previous ones, there 10 times the dose has been given. Here the dose is 0.05, the route is intradermal. But if you look at the TuberVac Onco-BCG literature and the package insert of the regular TuberVac that we use for vaccinating, 1 ml of the TuberVac which we use for BCG vaccination is 2 to 4 into 10 power 6 coloniform units.
Yes.
Whereas the Onco-BCG is 1 to 19 into 10 power 8.
Yes.
So this patient has received Mycobacterium of BCG origin nearly 10 power 2. 100 times the antigen load has been presented to this baby. Therefore, I would expect more papule, more nodule, probably more ulceration, and probably a longer reactive lymphadenitis in the left axilla, and probably sinus formation, abscess formation. But I think, again, apart from an apology and watchful expectancy, I don't think there is a real risk to this baby unless the baby is immunocompromised, in which case there is a risk of BCG.
Such a high dose, do you expect dissemination into the organs in an immunocompetent child? Such a massive dose?
Yes,
I think no, in an immunocompetent you will not. See, basically, I think the first time I had this child bought with this similar problem was about 2 years back. And subsequently, just about 3 or 4 weeks back, one more child. Now, the first child, I was at a loss. I didn't know what to do. I inquired with Dr. Jacob John. They said, just keep quiet, nothing to be done. I scanned the literature. There is only one literature report from Pakistan where on one single day, 23 children were given Onco-BCG instead of BCG in one hospital. I don't remember, Peshawar or Karachi.
Karachi.
There, Karachi was it? I remember in Pakistan. What they did is they gave antituberculous treatment for all these children. So I was in a fix. I discussed this with Dr. Jacob John. He said immunocompetent child BCG, no antituberculous treatment. The first child is very fine. The second child also, it's about a month. The child is fine. And as Dr. Ashwath has said, there was an exaggerated reaction. I got a papule towards the end of the first day itself, a pustule coming on around the second day. There was an ulcer around the end of 1 week. The ulcer kept on discharging for almost about 5 to 6 months and ultimately healed. There was no abscess formation. There was no lymph node. It healed, but it took a long, long time. Some reports say that you can do repeated aspiration of the local site so that I can remove out as much of antigen as it is there, but we really don't do anything. These are rather unusual adverse effects, but if you get it, you should not be bold. You should know what to do. So this is what has to be done. Any BCG, massive dose, wrong route in an immunocompetent child, no ATT. I think that is a message we need to be convey very, very clearly. Okay, now we come to the next vaccine, that is the Pertussis vaccine. Okay, now, Dr. Suresh, are there any recent studies from India showing the prevalence of Pertussis in different age groups? Please remember, in India, all reporting by the government is a clinical criteria and not a lab-proved pertussis. Anyone with a pertussis-like illness, according to the WHO categorization, is labeled as pertussis. It is going to overdiagnose pertussis. Do we have anything of proven pertussis in our country? Dr. Suresh?
So there are a few studies which talk about the prevalence of pertussis. Especially one is the 8 Asian country studies, which involved children with between 11 to 18-year adolescents. They found that 18% of the adolescents have titers of more than 62.5, which suggests that there is an exposure of pertussis within a year. That is one study. And another one study reported in IJP in May 21, Velu study, which says that adolescents, about 281 adolescents studied, 52% had no antibody titer.
Right.
These are the two studies.
Right. So these two studies, the first one, see, this titer 62.5 is indicative of pertussis in the past 1 year. A titer of 125 IU per ml is indicative of pertussis in the last 6 months. It's internationally accepted criteria. So most of the pertussis serosurveillance studies use these criteria. So these 8 Asian countries where there was a contribution of about 200 adolescents between 11 and 18 from India showed that 18% had titers above 62.5. So there's a lot of recent exposure to pertussis, and the Velo studies showed that 54% did not have antibodies at all. So they were susceptible to pertussis. So there's a strong need for pertussis vaccines in the later age groups and adolescents. So we definitely need pertussis vaccines. Now, another contentious issue. I want to be very brief, otherwise this will take off the entire panel discussion. What are the main advantages of WP vaccine? Just we know it is reactogenic, it causes this, that, and all that. But what are the main advantages?
So it offers a long-lasting immunity, sir, and disease protection, and is useful in the mass immunization program. And compared to acellular, there is a decrease in the drop in immunity. Actually, there is a drop in immunity of 2 to 10% every year, which is more with the acellular pertussis than ocell pertussis. And the risk of developing pertussis is lower compared to acellular pertussis. And it stimulates the natural infection. That is, there is an increase in the cell-mediated immunity as well as the T helper cells, one responsible for the clearance of the botrytis pertussis. That is very, very important. And there is a robust lymphocyte proliferation and cytokine response. And another one important thing is the tissue resident memory cells, which is important, TRM cells, which is important for protection against reinfection. These are all some of the advantages of ocell pertussis vaccine.
So basically, WP vaccine versus AP vaccines. WP vaccines gives marginally longer duration of protection. WP vaccines interfere the transmission because it reduces the nasopharyngeal carriage. But I think the most important advantage is long-term protection. See, when you prime the human being or the infant with a WP vaccine, their entire immunological process is skewed in a direction of a superior immune response. You see, whereby, and this superiority, this skewing towards a better immune response is almost lifelong. You see, there have been studies where they have taken 2 cohorts, AP prime, WP prime, 15 to 25 years, they have given a booster of AP and have found the vaccine response in those who are WP primed were just far superior to AP. So it is the duration of protection, the longer duration of protection, a superior immune response. But in spite of all these advantages, the reactogenicity is something we all fear. And that is the main reason why AP came into the picture. The whole issue is, what is the reactogenicity in the Indian population? You know, vaccine take and reactogenicity both are, subject to variation, geographical variations. We don't have any data. Okay, so I think we cannot just, dismiss of WP vaccines and say that it's not worth using. We should go only for the acellular vaccines. Okay, now, if you want to derive the benefit of WP vaccine and also have the advantage of AP vaccine, can you give the first dose of the WP vaccine and subsequent 2 doses as a acellular vaccine? Is this acceptable? Will it work? What do you feel about it?
Yes, sir. Because of the fear of the reactogenicity, as already highlighted by you, sir, that many of the countries are being using the acellular pertussis in their primary dose schedule as well. But when we see the studies, they say the population data, we see that individuals with the mixed AP and WP schedule have prolonged and higher vaccine efficacy with the primary WP vaccine and then the acellular pertussis vaccine. And in many countries, they have now recommended a primary AP and a single dose of WP. But whatever said and done, WP vaccine is the primary schedule, gives a more vaccine efficacy and protection.
Not only the primary schedule, the first dose should be a WP vaccine. If the first dose is AP and then you give WP, the advantage is lost. So if at all you give, and this is basically based on a study by Sarah Sheridan, where they looked at the attack rate during an outbreak of pertussis and found that attack rate was lowest in those who received a all WP. Next was those who received a mixed schedule with WP first dose. So that way, the first dose is very important. So I think many pediatricians are using this WP first dose followed by 2 APs. Nowhere is it recommended, but I think it makes a lot of sense using the schedule. You are utilizing the best of both.
But I have one doubt, sir. One doubt.
Yes, yes.
But practically, what we see is now after the introduction of all these 6-valent vaccines, most of them contain only the acellular pertussis.
Yes.
So how it is possible to give the first dose as WP?
Well, there is one brand which has WP.
Serum Institute.
Okay. Yeah, no, our Serum Institute is going to come out, but Chiron Panacea has one brand.
Okay.
So I think you can do it if you want to do it.
Okay.
Okay.
Yes. Sir.
Right. Now we administer Tdap at 10 years of age. Okay. What is the duration of protection against pertussis when Tdap is administered at 10 years of age? And let's forget about diphtheria and tetanus. Let's talk only about pertussis here because the discussion is on pertussis.
There are 2 studies. One is the Wisconsin study and the California study, which say the protective efficacy decreases after 4 years of age against pertussis.
Right. So in fact, they showed a very significant fall in titers to almost a little higher than the pre-vaccination titers within a year of giving it. And the protective efficacy went to negative values in the 4th year itself. So the duration of protection is very, very short against pertussis with the adolescent booster. This is something we need to keep. Now, I think we'll benefit. This is nothing to do. Now, again, coming back like influenza, the highest mortality to pertussis is in the very young infants who are too young to be immunized. And I think you are going to protect them with maternal immunization. So what is the efficacy of maternal immunization? Is it better than the response to maternal influenza, or is it the same? Is it better? What is it like? I think this question goes to Dr. Suresh.
So there is a study, sir, which says that the effectiveness of vaccination during pregnancy to prevent the infant pertussis and hospitalization, which says about the timing. And during pregnancy, he says it is a 2-month follow-up. The vaccine efficacy is around 91%, and 12 months is around 69%. And before pregnancy, it is 68 versus 59.9. And after pregnancy, it's around 45 and 24%.
So basically, maternal immunization with pertussis is much, much more effective than maternal immunization with influenza. There we were talking about 36% and 63. Here we are talking about 90s. And if you are doing maternal immunization, it has to be done in the 3rd trimester of pregnancy between 28 and 31 weeks. That's the time when optimum transfer of antibodies occur to the infant through the transplacental system. Giving it before pregnancy, you see the efficacy goes down a lot. In fact, efficacy is almost not there. You have negative values in the So maternal pertussis, 3rd trimester between 28 and 31 weeks, very effective in preventing hospitalization of severe disease, at least in the first 3 months of life. And the third point to remember, it has to be repeated during every pregnancy, irrespective of how frequently it occurs. Right? These are the 3 important take-home messages as far as maternal immunization against pertussis. I'm going a little fast now. Any new pertussis vaccines introduced anywhere in the world, Dr. Suresh?
Yes, sir. There are some genetically detoxified pertussis vaccines are there, which is either as a acellular pertussis and or as a Tdap. One is the Bionet PT gen, which is a genetically detoxified produced from a new recombinant Pertussis Tohama strain. So they are very effective, and considering the persistence of the elevated antibody response 3 years post-booster vaccination, genetically detoxified both the acellular as well as the Tdap vaccines can be expected to induce long-lasting protection than chemically inactivated Tdap vaccines when compared to the aerosol.
Right. So chemically detoxified Pertussis antigen, the major immunogenic epitopes are altered. So it becomes much less immunogenic. When you genetically detoxify it, the immunogenicity is retained. And you can just look at it. Look at the difference in the antibody titers between what you elicit with the chemically detoxified and what you're getting with the genetically. And look at the duration of protection. And this vaccines, Pertugen and Boostagen. Pertugen is only AP, reduced content. Boostagen is reduced content with tetanus and diphtheria. These are basically from Thailand. Bionet Asia is from Thailand, a very major vaccine manufacturer. And this vaccine is now also approved by the US FDA for children above the age of 11 years. Okay. And in fact, if it is available in our country, this is the vaccine which can be used for periodic boosters. And this can be a vaccine which can be used for maternal immunization, because it is going to give much higher antibody titers, more antibodies to the infant, and probably longer duration of protection. And maybe you may not need to give it in every pregnancy also. So this is one vaccine which is very, very good. Now, any vaccine which has a respiratory route of entry, it's always best to have a vaccine which occurs and which acts at the level of entry. You give rise to what is known as sterilizing immunity. And the same holds true for Pertussis. Are there any mucosal vaccines in the making?
So one vaccine is there with the BPZE1 vaccine, which is showing about a robust product versus specific antibody response with regard to significant increase in one or more of the following parameters. There's IgG, IgA, and memory B cells with the product versus antigens.
So I think very briefly, this is an intranasal vaccine. It has induced a much superior response compared to acellular vaccine. This vaccine also has just completed preclinical trials, and the authorization for phase 1 trials has been granted. And I think it is going to begin very soon. Okay, so this is something we'll be hopefully looking for, which will give us a very, very big advantages in prevention of pertussis. Right. Now we come to measles vaccine. When we talk about respiratory illness, we hardly talk about measles. We talk only about pneumococcal, we talk about HIB, we talk about tuberculosis, we talk about COVID and maybe, but we never talk about measles, without realizing that measles contributes to a very, very great extent in the etiology of pneumonias in our country. And if you look at this figure, this is recent data, published in February of this year. India has more than 61,562 cases of COVID reported in the past 1 year, and it's the top in the world. Okay, we know we have outbreaks everywhere in many parts of the country, in fact, many parts of the world. So, Dr. Vasanthi, what are the reasons for this resurgence?
As we all know, the pandemic has hit us with the COVID, and this is one of the main reasons for resurgence, because the children were not taken to the vaccination center and hence failure of timely vaccination is probably one of the major reasons. And as you know, that vaccination is the only strategy for to control measles, and the sustenance of vaccine coverage of more than 95% is the key. So unfortunately, a vaccine survey recently showed that the vaccine coverage is only 71% of measles containing vaccine at 9 to 12 months. Considering 85% vaccine efficacy for vaccination at 9 months, actual protection is actually conferred only 60% of the annual birth cohorts, and of which 40% cohorts remain still susceptible. That is, partly children are unimmunized, and 15% have failure to seroconvert. Hence, the need to promote vaccination and then to make it 95% to make it more efficacious.
Yeah, Dr. Vasanthi, there is a definite drawback of giving at 9 months, but you're overcoming that drawback by giving a second dose at 15 to 18 months. But what are the reasons for the resurgence? Why has it again flared up? Is it a vaccine failure, or is it a failure to give the vaccine? What is it? What has happened over here? Why the resurgence?
Probably a failure to vaccinate is the main reason.
Exactly.
Sir.
I think the COVID pandemic has disrupted, vaccination programs all over the world, more so in the developing countries. There is a lot of vaccine hesitancy against measles vaccine or MMR vaccine in most of the developed countries. And these two factors have been mainly responsible for the reduced uptake of measles vaccine and the outbreaks which are occurring now everywhere. I think in our country, vaccine hesitancy, I think, is not very, very well established. It's more of a failure to vaccinate which has given rise to this. Now, Dr. Vasanthi, you are in your clinic and you get a child whom you feel has measles. What will you do? What should you do? I'm not talking about the management of measles. As a responsible pediatrician, what is your commitment towards public health when you get a child with measles in your clinic?
The first point of contact of suspected measles cases would be the private practitioner. So any person in whom a clinician suspects measles, or any person with fever, a maculopapular rash, or cough and coryza or conjunctivitis is suspected to have measles. So the mechanisms of reporting are always simple and very efficient. Reports should be immediately submitted to the district or the provincial surveillance coordinators. In turn, this district or the provincial staff would again promptly report it to the national surveillance staff. So that is how I think every case of measles have to be reported immediately. And usually in the hospitals, the monthly report which we send of all the infectious cases. But when there is a incident of a measles case in the clinic, I think it is mandatory that we report immediately to the district or the provincial staff, or at least to the nearest PHC, so that it is made aware.
Very well said. I think it's the duty of every pediatrician to report every suspected case of measles. Don't try to, diagnose on basis of Koplik spot. You have a fever, 3 days, child coming with some rashes, report it. It's the business of the public health authorities to establish that, and they have their own. And second is, of course, you have to advise isolation of the child within the house itself.
Yes,
so these two factors are very important for if you diagnose a case of measles. I think we'll skip this. Now, Dr. Chandramohan, you have been quiet for some time. As I said, we don't take measles as purely a respiratory virus. Okay. But it's very important in prevention of respiratory infections. So what is the contribution of measles to pneumonia, morbidity, and mortality in our country, or taking the world or developing countries as a whole?
Actually, even after 60 years of the measles vaccination, still it's the most dreaded vaccine preventable disease against which there is effective vaccine available. So out of the 1.7 million vaccine preventable deaths, 44% are attributed to measles itself. And it doesn't only protect from measles, it also has a ripple effect where it protects from the other infections also. So India accounts for 14% of the measles deaths, and pneumonia, we all know that pneumonia and diarrhea are the most dreaded complications of measles that lead to the mortality due to measles. So pneumonia in the community status, it's around 15-20%, and in the hospital status, it's 16 to 77% of the hospitalized children have this complication of pneumonia, mostly due to the pneumococcus. Pneumonia contributes around 56 to 86% of all deaths attributed to measles. Measles per se does not cause much deaths, but this is the pneumonia which is responsible for about more than 60% deaths. So bacterial infections are a contributory factors, and around 50% of the cases where pneumococcus accounts for around 34 to 50%. So measles, it has been also observed during vaccination in the studies from the Congo, Pakistan, India, that even small ARI infections are also reduced with the measles vaccinations. So this measles vaccination is one of the greatest contributor to the public health by reducing 79% drops in measles death over the 15 years period from 2000 to 2015. And during this period, around 20.3 million deaths has been prevented by one public health intervention, that's the measles vaccine. So this cannot be overemphasized.
Right. So measles is an important cause for ARI mortality and morbidity in our country. It's not only the pneumococcus, and measles vaccines has worked quite well in overcoming some of these issues regarding mortality and morbidity. Now, quick fire questions. In an outbreak situation, can measles vaccine begin to infants less than 6 months of age, Dr. Ashwath? Yes, or
sir.
no?
Yes, sir.
Less than 6 months. Other
Yes, sir.
panelists' opinion?
Yes, sir.
No,
Yes.
I believe less than 6 months that immunoglobulins will only help. Otherwise, the vaccine
Yeah.
will not be of much help.
Yeah, so basically, I think below 6 months, the seroconversion is going to be extremely low. At 9 months only, it is 86%. At 6 months, it's going to be hardly 50%. So none of the public health measures so far advise less than 6 months during an outbreak. It's all 6 to 9 months. You give it, but take it as an additional dose or an invalid dose, and then continue the schedule once the child reaches appropriate age. Any new developments in measles vaccine? I think basically the main drawback of measles, I'll just skip a couple of questions because we are almost completing 2 hours of panel discussion. And I think we'll be asked to close down very soon. So main thing regarding measles vaccination is making the vaccine available to the people in the remote areas with people who are technically capable of administering injections. And that is being overcome by what is known as the microneedle patch for measles. And what is a microneedle patch? You have a micro needles of micron size, the diameter of a hair. They are either solid with coating of the measles antigen, or it may be hollow with measles antigen inserted. You apply it on the skin. The self-dissolving ones, they dissolve, release the antigen. The solid needles, you keep it on for about 5 days or 7 days and then remove it. And this antigen is taken up by the antigen presenting cells. And believe me, a lot of work is going on in this. Lot of work has gone in preclinical stage. Influenza vaccine has been investigated by this technique already in human beings, and this is being tested in humans. And already a target product profile has also been published by the WHO. So probably we are going to see this microneedle patch coming on in the next couple of years, and hoping to reach every nook and corner of the world where even the most difficult to reach can get the measles vaccine. Okay, now I come to one vaccine which is probably very, very important when we talk about respiratory infections and mortality, morbidity. Believe me, the whole scenario has changed, Initially, we believed that 1/3 of all pneumonias in developing countries were bacterial. And of that 1/3 was pneumococcal. That is what we always thought. But there was one study which came called the Perch study, which has changed the whole picture. Okay. So Dr. Ashwath, can you just elaborate on this study?
No,
a little
basically,
far, please.
no, what we have known from India is that all the collated data says that the RSV is the unsung villain of the piece. Whether it comes to acute respiratory infections, upper respiratory infections, lower respiratory infections, pneumonias, very severe pneumonias, all-cause mortality related to respiratory, RSV virus has not been given the due importance that pneumococcus or influenza virus has been given. So it is a major contributor in all the categories. ARI, ALRI, pneumonias and very severe pneumonias, and quite a few of them also have a bacterial superinfection. So definitely the respiratory syncytial virus contribution to respiratory morbidity in our country has been vastly under-recognized and under-reported.
So basically, I think the Perch study showed that almost 31% of all pneumonias, hospitalized pneumonias, were due to the RSV. And where does bacteria? Bacteria are only 21%. And this is from 7 countries, 5 from Africa, 2 from Asia. Asia was Bangladesh and Thailand, all low-income countries and low-middle-income countries. And India is one of them. So I think the whole changing or approach towards prevention of pneumonia is changing. And why RSV? I don't agree that it has not received its due attention. The only thing is getting an RSV vaccine has been extremely difficult. And there is a lot of data, even from our own country, the CAPE study from Chandigarh. And this was a very nice systemic review of RSV studies from our country. Please go through it. I have put the references also, where it shows that there's a very significant burden of RSV in our country. And there is a very, very active pipeline of RSV vaccines and even RSV immunologicals. And in fact, nirsevimab is also going to be, rolled out in the market by Sanofi in our country also. So, which new vaccines we'll take only the vaccines which completed phase 3 trials. Which vaccines have completed phase 3 trials? Dr. Ashwath.
So the most important antigenic component, like we talk about hemagglutinin and neuraminidase for influenza, the most important protein as far as the RSV is concerned is called the fusion protein or the F protein. So it has two forms, the pre-F form and the post-F form. So what investigators are trying to do is take the F protein and conjugate it either to alum or use alum as an adjuvant or ASO as an adjuvant, or tag F protein along with some other vaccine carrier like the adenovirus and try to induce an immune response, because they believe that the anti-F protein titers are the best correlates of protection against RSV virus. So the PREPARE trial, the Matisse trial, the GRACE trial, there are quite a few trials, all of them which have been given for pregnant mothers to prevent respiratory syncytial virus in the infants, much like the influenza vaccination for pregnant mothers to reduce the dose of influenza in the infants. And they've all shown fairly good and promising results. The other vaccines that have been done are the RNA vaccines and the targeted virus vaccine carrying agents like the adenovirus or the MVA, wherein the viral proteins have been used using a viral vector. These are the three vaccines which have undergone the trial, but the most experience is with the F protein vaccines.
Right. Now, RSV vaccine is also targeting certain population groups. One is the child who actually suffers the infection, the mother maternal immunization to prevent RSV disease in the newborns, and the elderly. Elderly are equally prone to RSV morbidity and mortality, as much as it occurs in the pediatric age group. So the first vaccine against maternal infection was called Resvax. And this was by Novavax, the company which has made that, which is the precursor of Covavax, our COVID vaccine. Now, this vaccine was based on the post-fusion protein, and hence it did not pass the exams, and it failed to meet the pre-specified primary outcome. Of course, they are doing a lot of improvement, and maybe things may change, but as of now, no licensure. The second vaccine is, of course, the GSK vaccine, which has completed phase 3 in older adults, excellent results, against severe disease, even in those very elderly and even those with comorbidity, over 90% efficacy. So this is a vaccine where GSK is now going to apply for licensure. This study has not been published. The third is the Pfizer's Matisse trial, which was maternal immunization. And this study has also shown very good results in preventing severe medically attended LRTI, 81.8% in the first 90 days. But when they extended the observation to 6 months, that is 180 days, it did not show statistically significant results. However, this vaccine also is going to be, they are applying for licensures. And finally, this Pfizer bivalent RSV prefusion protein. See, all these vaccines are prefusion except the Resvax. So this is the only vaccine which has published data in NEJM just this month, April 5th, it has been published, and it has shown a very good response. And I think Pfizer is also applying it for licensure and usage to the US FDA. So I think once RSV vaccine comes into the picture, I think the whole face of ALRI is going to change in our country. And especially if it has become available in the NIP of our country, there's going to be a sea change in the picture of RSV all over the world, in developed and developing countries as well. So finally, you cannot forget COVID. Okay, COVID is a respiratory virus. I don't know, people have lost interest in vaccines against COVID now, I think, because almost the whole world has received and nothing new has come. Of course, pediatric population is not very well covered. And Dr. Vasanti, just briefly, why, most of the vaccines have been licensed from 5 years onwards, but has not been rolled out. Why has it not been rolled out? Is it that the need for the vaccine is less? Or is it that the vaccine is not available? Why has it not been rolled out? 12 to 17, yes, but vaccines have been studied from 5 years onwards, but they have not been licensed. In fact, Covaxin has been studied from the age of 2 years, but still not been rolled out. What are your views? There's no textbook answer for this question. What are your views?
So they have probably got the EUA, that is emergency situation at the authorization, but
Yes.
I think the National Technical Advisory Group is still not convinced about the utility of this vaccine in the much younger age group. So they feel that the young ones may not they may not become very sick because of COVID vaccination. I'm sorry, because of COVID illness per se, and hence I think they've not still rolled out the vaccines as yet. This is my
I think basically what has happened is, and the pediatric authorization came almost when the Omicron wave was at its peak. By the time Omicron came wave down it came down very rapidly. I mean, there was a loss of interest. And moreover, there was so much money the government had spent on COVID, handling COVID and the vaccines, that they were no longer interested in, utilizing it for a population who are relatively spared of many of the complications of COVID. Unlike USA, where they're giving now, USA, the mRNA vaccine of Pfizer has now entered the routine immunization at 6 months of age. So like you give influenza at 6 months, they offer the COVID vaccine also. So that situation has not occurred in India, and I think rightly so also. Covaxin versus Corbevax or Covax, what is your take? Very briefly.
The Covaxin actually is a virion, whole virion protein, and then the vaccine efficacy is as high as 81%. May not produce much of a side effect because it's a dead virus, able to promote a defensive reaction against the infection. Again, Corbevax is a protein subunit vaccine, which is against a spike protein, and it has the component, the receptor binding domain as a component which is derived from the spike protein. The efficacy is almost as high as 90%. Covax again has an efficacy of almost 98% on day 36 of the immunization. Highly immunogenic in children older than 12 years. It's a recombinant spike protein nanoparticle vaccine. So I think
so
taking all these vaccines, I think each of these are equally efficacious.
Their own. See, and Covaxin is like your wholesale Pertussis. It's a dark horse. Okay. Corbevax, Covax, both are subunit vaccines. Next to mRNA vaccines, subunit vaccines elicit the highest antibody titers. Corbevax is only the receptor binding domain, whereas Covax is the entire full-length S protein. So if you have some mutations in the receptor binding domain region, efficacy of Corbevax may suffer very badly. So these are the differences. I think booster for children and adolescents, I think any views?
Only thing it's
no one wants to give any views also, because I think basically now, once you have taken the primary immunization, you have got enough of T-cell response to prevent severe disease. If you take an additional dose, a booster dose, the booster response to the T-cells is very minimal. Okay, your response is mainly to the neutralizing, to the humoral immunity, and not to the T-cell immunity. So whether it has much of a role today is very, very debatable, except for the very high-risk populations. So I think with this, we have finished our panel discussion. If the organizers still have any patience, we can take some questions as well. Thank you. Thank the panelists a lot. I think excellent performance. Thank you.
Thank you, sir.
Sir, we are already running in time, actually.
We are,
Yeah, I think,
so maybe that they have asked the questions, so you can put up the answers in the channel, sir, in the chat box. Janani ma'am,
Yeah. So I
that
think
we'll keep the
we
chat
have,
box open for some more time so that the answers can be just 5 or 6.
okay.
Yeah. Thank you,
Fine,
sir.
let's share all. Thank you.
Thank you, sir.
Thank you, sir.
yeah,
Thank you.
Thank you.
Thank you very much. Thank
Yeah,
Janani
thanks,
ma'am, your
thanks to all.
final words, ma'am.
Yeah, I
sir,
think it was
Janani.
a wonderful panel. I think it was very detailed and elaborate and clarified all our queries related to the vaccines, respiratory vaccines. So we didn't want to, hurry you all up, and we wanted to give you adequate time. So we given you extra half an hour.
Yeah.
So I think any questions, I think can directly send a mail to Dr. Kasi and get the answer.
Yeah. And we had all 100 participants remaining till the end, madam.
Yes. That shows the interest. Yeah.
So that
So
the
I think-
viewership did not drop
No,
at
I
all.
think so. We'll read out something nice. Absolutely top-notch webinar.
Yeah.
Most of the pertinent practical questions were answered. Wonderfully moderated by Dr. Kasi. An excellent discussion by all panelists. So, sir, you're truly inspiring and versatile. So, thank you so much,
Thank
sir.
you.
Thank you so much. Thank you,
Thank
panelists
you
also.
so much. Thank you. Yeah. Thanks to all the panelists for the wonderful discussion. So I think any questions further beyond this, I think it was
Yeah, I
so
think the chat
well
box can be
discussed.
kept open for another 10 minutes,
Yeah,
madam, so that
more than
they
that,
can-
Narmada, it was so
Yeah, ma'am.
well discussed
Yeah.
in such an elaborate manner. I don't think they'll have anything.
They will have any questions. Yes, ma'am. That's
Yeah,
true.
if at all they have, they can directly send a mail to Dr. Kasi or talk to him and clarify.
Sure, ma'am. Yeah. Thank you. Thank you so much, sir. Thank you so much.
Thank
sir.
you.
Thank you. Thank you.
everyone.
Thank you, sir.
So
Thank you.
thank you, Tamil Nadu team. Thank you, Kasi sir.
Thank you all, sir.
Thank you, Thirumurugan sir, for all the help.
Thank you, ma'am.
Thank you.
Thank you, Suresh Balan.
Wonderful.
Thank you.
Thank you. Bye-bye.
Thank you. Good
Thank you,
night.
Kasi sir. Thank you very much.
Thank
Thank you,
you.
sir.
Thank
Good night,
you
sir.
very much.
No, there's
Thank
one
you.
question, sir. Sorry. I think this Dr. Kamalakanan had asked this question even before. I think that alone you can please answer, sir.
Which
Before
question?
you log out. Now the recent strain of influenza vaccine is available and claimed to be effective against the recent H3N2, H3N1 and CT. Is it okay to give an extra dose if the original due is around August or September? So he just wants to know.
I think there is no recommendation for 2 doses in 1 year anywhere in the world. Okay.
So then,
In fact, I had put up one question which I removed because I didn't want to create confusion. Suppose you have a child with a very high risk for influenza. Will you give him 2 doses every year? There's no recommendation. So I think recommendation is only 1 dose per season.
Just 1 dose. Yeah.
Yes.
Okay.
There's no recommendation. And I'll just answer this Onco-BCG. Remember, in hospitals and nursing homes, you have patients with bladder cancer getting admitted for intravesical installation of Onco-BCG. And if you look at the vials of Onco-BCG and our Tubervac, only difference is the color of the label. Yellow, Oncovac is yellow, and this is, I think, purple in color. Bluish in color. And there's that vial is a little bigger compared to the regular. And I mean, imagine in my own practice, 2 cases I have seen in the last 1 or 2 years means it may be happening elsewhere and being hushed up. I don't know. But I think we need to be very clear about it. We need to know what to do if such a thing occurs. Thank you.
Thank you so much, sir. I think not many other questions. So thanks to Dr. Kasi and all the panelists and Dr. Thirumurugan for giving us the Zoom platform and adequate time and also the maximum number of participants to enter. Thank you. Thank you all.
Thank you very much,
you.
sir.
Thank you.
My special thanks to
Thank you very much, sir.
President Dr. Suresh Balan sir and all the panelists for really enlightening us. It was some very difficult questions answered in the best possible way. So thank you, everyone. And we look forward to more such webinars from the infectious disease chapter. So thank you very much and good night.
Thank you.
Good night.
Bye.
Thank you.